Okay, everyone, we are going to try this again. I just started a few minutes ago, but then I lost my internet connection, so I hope that doesn't happen again. Welcome to I Care for Your Brain. My name is Dr. Karen Sullivan, and I am back with you with another Facebook Live lecture. We are continuing on the theme of essential tremor tonight. We continue to try our best to meet the unmet needs of this community. Come to terms with the fact that this is not a one-symptom disorder, and in fact, this is a multi-system neuropsychological disorder. So we are gearing up around here for our very exciting webinar coming up on June 26th with 4 hours of programming on the non-motor symptoms of essential tremor. We're not going to be talking about all the typical things you can find online or on Google. We're really going to be doing a deep dive into these non-motor symptoms. So everything that you experience in your body that you try to talk to your doctors about, but they don't seem to really get it and be able to put it together, especially the cognitive symptoms, the social symptoms, and how it impacts how you feel about yourself. And really the goal is to educate and empower you to where you can live a life of the highest quality, where your values are not compromised by the symptoms of ET that you have. So I'm going to give you some more information at the end of this lecture on the webinar, but you can go to www.icfyb.com/ and you can find out more information there. So tonight we're going to talk about sleep and essential tremor. This is yet another underidentified, undervalidated, underassessed, and undertreated non-motor symptom in ET. Note I did not say underreported. This is also another aspect where we see overlap between Parkinson's disease and essential tremor. And in fact, this lecture was inspired tonight by a listener who wrote to me and said that she was concerned, even though she'd been diagnosed with ET, she believes she's having some symptoms of a condition called Rem Sleep Disorder, and was concerned that that possibly meant she actually had Parkinson's. So we all know that ET often is poorly diagnosed, and we often use just the course of someone's illness to figure out what their most appropriate diagnosis is. So this really led me to want to investigate, do we also see REM sleep disorder in ET? And it turns out we do. It's just not at the same high frequency that we see in Parkinson's. So that's just one of the things I want to talk to you about tonight. So we're going to review everything we know about sleep and how it intersects with ET. So my first question for you is, do you understand how important sleep is for your cognitive health, your physical health, and your emotional health? We finally, we think, have a sound scientific theory on why we spend a third of our lives unconscious. They have been through the ringer with folks who study this kind of thing, but we have finally come to an understanding that deep sleep in particular really does 3 restorative functions for us. And this is a cleaning out process, making memories, and processing emotional thing that we can talk about another day. But in essence, as our brain is working and the cells in our brain are functioning, they have products that are kind of like the garbage that get kicked out after they do their jobs. And all of this stuff has to be swept up, put into nice little trash bags, and disposed of. And that's a big part of what happens during deep sleep. So if you can't do that, you're going to have inflammation, and you're just going to have a lot of gunk in there that prevents blood flow. The next thing we know is that we actually review the day's events when we're sleeping, and we make decisions about what to keep and store into long-term memory. And the reason why we have to do this is we don't have enough brain matter to store every single thing that happens to us every single day. So we have to pick and choose. The third one is processing emotional trauma. The function of our lives, our brain, our DNA, is to stay alive long enough to reproduce. And so in essence, you can really think of us as having selfish genes. They really want to go on and be able to propagate. And so when anything traumatizing or threatening or concerning for our safety happens, our brain is very concerned about that because it might mean that we can't reproduce. So a lot of times in our sleep, we're really going over anything threatening, anything that felt like it could take our precious resources, because the brain wants to deduce, what is the lesson here? How can I face this threat better next time? So if you aren't doing those things, you are going to have a fair amount of trouble to You are going to struggle with your physiology, and you're going to struggle with your psychology. So in the world of sleep problems, we actually have two sets of issues. So the first one are symptoms, and the next one are disorders. So when I say symptoms, this is what you doctor and report, okay? This is subjective. This isn't necessarily reliable, because you know why? We're not great reporters about our sleep. We actually tend to over-report sleep problems, and we quality sleep. And so we're not the best at just using our words and our memories to tell sleep specialists exactly. We also have sleep disorders, and you can only diagnose a sleep disorder by something called a sleep study, which is also polysomnography, okay? This is when you go into a doctor's office and they record your brain waves, the oxygen level in your blood, your heart rate, your breathing, your eye movements, your leg movements. It's really the purpose is to study sleep architecture. Sleep happens in very specific stages. You can't skip the stages. If you get pulled out of sleep, you start right back at the beginning. So what we need is to know what are the pathological events that are happening during sleep. We need an objective voice in the sleep evaluation. So the literature on symptoms and sleep disorders in Parkinson's are super clear, okay? Sleep has been known as a non-motor symptom in Parkinson's for a long time. And this is mostly because of the chemical that's involved in PD, which is dopamine, which is a big player in the regulation of the sleep-wake cycle, really helping to keep our circadian rhythm in a 24-hour cycle. So when we don't have that, we take dopamine drugs to put more dopamine into our body. The problem is it's not a perfect system, and we don't upregulate them. We don't absorb them in a perfectly fluid and level fashion. There's a lot of ups and downs. Any of you that take Parkinson's meds, exactly what I'm talking about. So as a result, we know that the sleep problems are either due to the PD itself or medication. So within PD itself, we actually know that the disease sets up in the brainstem, and this is where Rem Sleep Disorder specifically begins. So when I say Rem Sleep Disorder, I want to demystify that statement because it sounds kind of medical terminology. It's basically a sleep disorder that causes you to violently act out very vivid, unpleasant dreams with either vocalizations, yelling out, sudden violent arm movements, leg movements, also called dream enacting behavior. And I have heard people say it's, they've witnessed people riding a bike. It doesn't always happen. But we know that this ability to not be paralyzed during REM sleep is because the brainstem isn't necessarily working as well as it should be. The exact cause of REM sleep disorder across humans, never mind Parkinson's or ET, is generally unknown, but we do associate it with various degenerative conditions of the brain. So of course, Parkinson's, multisystem atrophy, and Lewy body dementia. If you don't have a neurological 55% of the time, it's actually really hard to pin down the cause. But for about 45% of the people, it can be related to alcohol withdrawal, trying to too quickly get off antidepressants like Prozac or Zoloft, or sometimes also other atypical antidepressants like mirtazapine. So don't ever stop any of those medications too quick, okay? In Parkinson's, we actually know that REM sleep disorder is one of the earliest symptoms that ever happen. So people can have it 10, 15 years before they get any type of tremor. And in fact, about 40% of people who have REM sleep disorder will go on to develop Parkinson's disease, okay? So it turns out, like I said before, that REM sleep disorder does happen in ET more commonly than in the general public, but actually much less than in Parkinson's disease. So again, we have to continue with our education that ET is not a one symptom disorder. It is not simply shaky. The very first study connecting ET and sleep disorder came out in 2015, and it just relied on those subjective measures. So asking people, how is it that you sleep at night? And all they did was compare the report of people with ET and people with PD. Now, obviously, when you ask people about a time when they're unconscious, it's pretty prone to error. But the most common sleep disorder, or sleep symptoms, reported by ET folks was just bad quality sleep and feeling daytime sleepiness, which a lot of people were thinking were related to drugs like propranolol that might help with tremor, but also might make people feel a little bit sedated. So what they actually showed was that in terms of sleep quality, normal controls are here. folks with ET are here, and people with Parkinson's actually get hit the hardest. So they think of ET as containing a mild form of sleep disruption. But remember what I said before, the subjective complaints only get us so far. We really need to take it to that next level of having the sleep study. So this is the gold standard, okay? So there's been very few studies that I would consider of high quality with sleep studies using ET populations. But there are about 3 findings that have been replicated, and I wanted to share those with you tonight. So remember, like I said, Rem sleep disorder does happen in ET, just not at the same frequency. In Parkinson's, this is a bit of a side note, but the 4 non-motor symptoms that we know happen before motor deficit. So if you're worried about Rem sleep disorder, like my listener, you also want to look for these 3 other symptoms. So trouble with smell, depression, and constipation. Those are the 3 things with Rem sleep disorder that come along when someone is going down the pipeline of developing Parkinson's. The other one is, like I said, we do know that Rem sleep disorder happens with ET, just not as much. And we also know that folks with shorter sleep duration tend to be at a higher risk for developing ET. So what this tells me is that people who have a later onset, maybe in that 5 years before they start to develop a tremor, they might have noticed that they're having trouble staying asleep or falling asleep. So there's 2 types of insomnia. We're going to talk about those in a minute. So with Rem sleep disorder, if you are concerned, again, you want a sleep study because you don't know, you could be jerking out of a dream due to a nightmare, you could have sleepwalking, you could have night terrors, you could have nocturnal seizures, you could have obstructive sleep apnea, you could have hypnopompic hallucinations, you could have nocturnal panic disorder, you could have post-traumatic stress disorder. Just because you jerk out of sleep, it does not mean it is Rem sleep disorder, okay? So one study suggests that just thinking you have Rem sleep disorder, just by history, okay, not having a sleep study, only 33% of those people actually have it. So again, we are poor reporters of our own sleep, and what those people usually wind up having is sleep apnea, which is an extremely treatable sleep disorder. So again, remember the gold standard is you pay attention to what's going on with you, bring it to your doctor, they should order a sleep study, and then you're able to really try to figure things out. The second finding is that ET folks do have more insomnia than folks with PD and controls. So what does this mean? There's 2 types of insomnia. You can have insomnia, which means you have difficulty falling asleep at the beginning of the night, or you can have maintenance insomnia, which is trouble staying asleep. So if that's you, I want you to chime in here and tell me which one feels like that best captures you. The third finding is that Parkinson's folks actually, if you look at objective data, they have higher excessive daytime sleepiness than folks with essential tremor, okay? And again, even though the medicines for ET have been tied to making you tired during the day, we actually think that daytime sleepiness is a primary feature of Parkinson's disease. So there's probably medications that affect both disorders. Folks with Parkinson's tend to be a lot more tired and draggy during the day. So based on my research, I have 4 recommendations for you. Are you ready? The first one, and this is probably the only technology that I consistently recommend to my people, my patients, and you on here, is to invest in a sleep tracker, one of those wearable sleep things. They are not that expensive. Even if you can't afford one, you can keep a sleep log and share this information with your provider. What I want you to be convinced of is that objective data matters. Sleep trackers are amazing. They can tell you how much deep sleep you get, how much REM, how much light sleep, how many times you wake up, how many minutes it takes you to fall asleep. It is an objective source of information. I'm telling you, you're either going to be surprised that you actually sleep more than you think you do, or you might be surprised because you think you sleep better than you actually do. The second recommendation is try low-dose melatonin. We've talked about this before. Again, this is probably one of 2 supplements that I actually support across the board. So there's no studies that I could find looking at how melatonin affects folks with ET, but It is definitely accepted for not just its help with regulating the sleep-wake cycle in anyone, it actually has some very protective effects for the brain in particular. So one of the things we know it does is synchronize the sleep-wake cycle, the circadian rhythm. It also protects the brain against oxidative stress. This is key. Helps to regulate energy metabolism so we can sustain our energy, our mental energy, for more times in the day. It modulates the immune system, and you should be worried about your immune system right now. And it also postpones the aging process. And a lot of this sounds a little too good to be true. And if you follow me, you know I'm a big science-based neuropsychologist, and so I would not be blowing smoke and telling you to go buy something that I didn't think would actually help you. You want to buy the lowest possible dose of melatonin that you can. Less is more, I promise. You can also get melatonin naturally in things like nuts, seeds, fruits, or vegetables, okay? So why not try it? I don't know of any data to support that it can have negative effects, but what I do want you to avoid, please, 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 is over-the-counter sleep aids. They are one of the most harmful things to the brain. They literally put a chemical into your brain that the memory medications on the market, like donepezil and Aricept, put in, okay? So you don't want to be taking out this chemical, acetylcholine, in your brain that, if you have Alzheimer's, is part of the problem, okay? So please stay away from anything over the counter, Advil PM, Tylenol PM, all that stuff. There's a lot of data to support the idea that it can really cause problems in folks with memory issues or any brain health condition. And my third recommendation is to exercise midday. There is solid evidence that if you exercise in the beginning part of the afternoon, you will fall asleep more quickly and it will improve the quality of your sleep. Specifically, moderate aerobic exercise really helps with slow wave sleep, which is also deep sleep. This is really where the brain gets into that clearing out action. It's when we start to make all of those new memories. That is the most important thing, is high quality deep sleep. We also know that aerobic exercise helps us to release endorphins, which, my goodness gracious, don't we all want more of that? We also know it raises our core body temperature, which, interestingly enough, is a state that actually helps us feel a little bit drowsy and helps us stay asleep. Now remember, just because you have, this is my fourth recommendation, is don't think that everything that's going on with you or wrong with you necessarily comes back to your brain health challenge, comes back to ET. Just because you have ET doesn't mean you can't get obstructive sleep apnea, you can't have restless leg syndrome, you can't get nightmares. This, particularly emotional trauma, nightmares, is a very undervalidated part of having a medical condition. For many people, it can be a very emotionally traumatizing thing, especially with the way some doctors communicate to their patients. They can just drop the diagnosis, there's no solid education, see you in 6 months, and people are left to do their own research, and it's not okay. That's why we feel so strongly here. Very, very high quality recommendations for folks with disorders that don't get enough attention in the general mainstream doctor-patient relationship. I'm trying to work with my internet going in and out. If you thought this Facebook Live was interesting, I would really love for you to read more about our webinar on the link below here in the comments and consider joining us. It's 4 hours of content, all non-motor symptoms, validation, education, healing, transformation. My co-host, Dr. Renfro, and I are working so hard to make it the highest quality education event that you could possibly participate in. We are limiting it to 100 folks, and we are definitely creeping up towards having to cut it off because we want it to be an interactive, high-level education experience. We don't want to just do it for the masses. We want to have a interactive experience where we are both learning. That is a big part of the philosophy of I Care for Your Brain, is we are not the only experts in the room. You are living with this condition. So guess what? You tell us what we don't know, and the idea is we share our expertise back with you. I think that's the only true way clinical care can really happen. So thank you guys. I hope this broadcast wasn't too glitchy. I don't know if we're getting a storm here in North Carolina or what, but I so appreciate you being here, and it would really be our pleasure to see you at the webinar. So take care. Dr. Renfro is actually going to be back next Wednesday. This is our last Facebook Live before our webinar, and she's going to be talking about something really cool. We're sticking with ET because we are in the zone. She's going to be talking about those of you who have head tremors and how that is different than folks who have ET either in their upper extremities, in their trunk, in their voice, or in their lower extremities. So head tremors, it turns out from our research, there are some unique differences that we want you all to know about. So please tune in and share that time with us next week. Thank you guys so much, and take care. Bye-bye.